Excuse me. Hello. Are you settled? I can see there is some big meeting going on between you three. Yeah, you three. Okay guys, now the subject which I have to cover today, it stays one of the very important surgical thing which anyone who wants to pursue his career in surgery, in initial training part, in residency part, thyroid is something which you should be knowing. And then the parathyroid is not only for surgical people, but for those who will be going into orthopedics and like any walk of life, you will be come across with calcium and all these things, and that's part and part of the thing. And about thyroid, it's a very commonly occurring problem, and those who have it, I don't know you have seen such patients or not. Have you started going to the clinics or yet?
No, yet.
But the pathology part has started with you guys. Yes. So I'll try to be brief with the things. There are so many details, and this lecture has two parts. One part I'll be covering today. The second part I'll be covering tomorrow. The tomorrow's part will be more pertaining to the developmental part as well as the more of the clinics. The clinical application and perspective and things and anomalies and the conditions which are commonly occurring in the different people. So for today I'll be more focused on to the gross anatomy part. I'll try to touch upon a bit of microscopic part of it. Let's see how it goes. So anyway, this is what is in front of you. I know you are familiar with. Now you have done your head and neck region. So I presume that will be good with the anatomy of the larynx. If you say no, I'm really surprised.
No.
I was so where you are covering the larynx? Yeah, you done that. Do you remember? You recall?
No.
I know you didn't. Anyway, thyroid, let me say a few words about thyroid. Larynx. Larynx is what? The sound box. And it is the continuation. In one term, it is the continuation of the pharynx. Actually, it's not. But pharynx communicates with the larynx because the nose, it opens into the nasopharynx. And all the air and air pertaining things, they have been brought to the larynx through its inlet, and that part of the pharynx, laryngopharynx, and then from there onward. And if we talk broadly, what larynx is basically some cartilages, some membranes, some ligaments, and some muscles. They are working together. In common words, we use this term for this particular region. They call it air box or sound box. You might have seen some people, because of malignancy, because of cancer, their larynx have been removed and they are holding a device, and if they want to talk to you, they put it here and they talk in a robotic or mechanical voice. So this is the application. If someone's larynx is not there, it doesn't mean the person cannot talk, cannot communicate. But larynx is very important. So far so, the air exchange and our talking, walking, all these, those who are vocalists and all that, if their larynx has some problem, their career has gone. Right? And anyone whose larynx having some problem cannot function, cannot communicate, only sign language and other things can come into play, otherwise you know what sounds can be coming from his or her mouth. Thyroid basically is an endocrine gland, but it has a very peculiarity that it is the only endocrine gland whose doesn't have secretion within it, it is outside that. Now the larynx part, as I said, these are the cartilages. The one of the most important cartilage, which we will be knowing a little bit of it, this one, which is like a shield, and that is called the thyroid cartilage. It's very prominent in men. You can see the Adam's apple, it moves when you swallow. Below to that, we have another cartilage that's like a ring, which you wore or you'll be wearing it. So it's called the cricoid cartilage. Then we have a leaf-like thing, that is epiglottis. The function of that epiglottis thing, it prevents the entry of any unwanted substance into the vicinity of the larynx. It prevents going into the airway. So that is an epiglottis. Then there are small cartilages. They are paired and unpaired, arytenoid, corniculate and piniform. Only you will understand when you will have real model in front of you. My job is to restrict myself towards the thyroid because itself thyroid is a long subject. So, what's wrong? Excuse me. Now, before going to the detail of the thyroid, we need to know little of the neck. I know you are very rich in the neck. You had around 6 lectures over that subject, and you'll be knowing more than me at the moment because you are fresh with that. Anyway, let's recap. Guys, I need your little cooperation, not much. So, under this mandible thing, what you can see, this white structure here is the hyoid bone. It's the bone which hangs in between. It has no any specific bony attachment. It's hanging in between, and it's basically carrying a group of muscles above to it and a group of muscles below to it, and they are called suprahyoid and infrahyoid. Hyoid word comes from this name, and then below to that you can see the cartilages of the larynx. On top of it, this shield-like thing, thyroid cartilage, cricoid, and then down starts what? The tracheal rings. And you can see here, this green thing, which is shown here, is itself the thyroid gland. And there you can see a very important structure. And this is here you have sternocleidomastoid. So there goes the common carotid. And there what you can see here, external jugular, and there you can see the anterior jugular, and they are opening into this internal jugular, which is hiding. So this sternocleidomastoid is a very important muscle. Under this, so many common things are hiding, or close to this, so many important things are residing. So while dealing with, while doing anything, in this area, one has to be extra cautious, because if God forbidden, this carotid or jugular has little trauma or little nick or little pinch, it is not forgiving, and then you hurt. So this area is very important while dealing with the sternocleidomastoid, because at its place where it's attached to the sternum and the clavicle, you can see these vessels are just underneath, and this provides us an easy access. Rather, when we are declaring someone is dead or dying or okay, and when we are not able to palpate for these radial pulses, the carotid is the place where we usually go. But remember, never put hands on two carotids simultaneous in one go, otherwise you'll create more trauma, a second trauma you'll initiate. So just one hand, okay? Be careful. So this carotid provides you an access, and then this internal jugular vein. In some of the persons where you don't have an access to a vein and person is dying in front of you, so as an emergency maneuver, you have to do something. And there, but as long as you are expert, people can cannulate this internal jugular vein, and from there you can give life-saving things and fluids and blood and what's needed. It's a portal for all that, right? So these are making a very good access on one hand, on other hand you have to be extra careful. And then you have here down the subclavians, which provides you a very important route for the insertion of the catheters, which are going to the heart. You are putting up the CVP lines, which are life-saving maneuvers, usually done when you are putting the patient in high dependency unit or intensive care units. There CVP line is one of the mandatory stay. So these all structures, they are very close. Some important nerves are going on here. So one has to be very careful. And another very important thing, if someone has a severe airway problem and there is an obstruction, you might lose person with infections. So in that time, we do tracheostomy. We make an access to this trapped air. So for that purposes, there we insert this place or this place. As an emergency maneuver, people can insert a wide bore cannula. At least relieve that. Make person survive. Help him. And then you can do the definitive procedure. So it's one of the emergency maneuver that you can insert a large bore cannula from this place, and there you can save someone from dying. So these all are very important and very vital things which are very closely related. Now why I'm emphasizing too much on all these things? Because you see thyroid is here, and this thyroid gland, when we have the act of swallowing, this gland moves because this gland is attached superiorly and inferiorly with fascias. So when we swallow, you can see very clearly, like one of the very important diagnostic examination part, like you ask the patient, kindly swallow something, and with the act of swallowing, you can identify the movement, and that gives you. But tomorrow we'll be talking more of, there are some thyroids which are not in the neck. Those thyroids, they can be behind the sternum. They can be in the chest wall. That is possible. That's a rare thing, but it is there. So in those individuals you will not find. So thyroid is in the newly youngsters, thyroid is normally physiologically palpable. So don't be deceived by that. But then after, there are so many pathological conditions which are pertinent to this particular gland. Now, this picture is more focused. Again, it's an look for your perspective. The most important thing in learning anatomy should be the functional perspective. And that starts with a good knowledge of surface anatomy. If you don't know about surface anatomy, how you can approach to a particular organ. So you should be focused on surface anatomy part and the functional perspective. We are not keeping you for the traditional type of old-fashioned conventional anatomy where we are talking of this way and that way and up and down. That if someone is really interested, if he or she is going into ENT, he can manage himself. But at the moment, you should be a good functional physician. And how it will be? Because if you know, if you have a sound knowledge of surface marking of the things, you can appreciate. If someone, patient will never come and say to you, doctor, I have a thyroid problem. He will tell you,